only my part. So we're not recording your presence here because of privacy. We're just recording my presentation here for your future reference. Like I said, so you can access it. We'll send you the link so you can play it back on your own in order to use it as a learning tools. So sometimes complex lectures like these are required to play back a few times before someone can start grasping the relevant material. So that is why we were told by the administration to record some of these complex lecture and put it up on the LMS or share it with your email. I'm going to share the link with your email. So when you think that something is not clear, then you can play back the this lecture on your own study time, and you can play it back part by part or whatever it fits your own little goal. But for complex lecture, this works very, very well. Cervical chordotomy. Okay, so what were we talking about? We are talking about the cervical nerves that are emerging from the cervical vertebra. The nerve root that becomes the cord structure. Nerve root, once it comes out from the anterior and posterior area of the cervical vertebra, they become cord structure. And this cord then divided back to branches, and they become track. And that is how we get the brachial plexus, those ulnar nerve, radial nerve, medial nerve that we are seeing working on our hand. They are basically coming out from the cervical 1 to 7 vertebra. The merging of multiple nerve root gives rise to the branches of brachial plexus. Very complex area, brachial plexus. We're not going to have to go in details what is in there unless you are an anatomy student. If you want to learn about it, if you look up the Gray's Anatomy for referral, you get great picture for ebook Gray's Anatomy, and you can read and learn the brachial plexus for your own fun. You can actually relate that to your own arm structure, axillar structure. You may feel ulnar nerve, how it is running through the elbow area. You can do all those fun work just because of you are interested. You may do that on your own. But for our learning requirement, we need to know anterior part is the motor that causes all the movement for the arm. Cervical area works C1, cervical 1 to C7. These vertebrae, these area of the spinal cord makes the reflex action of the hand. Anterior part of this cervical area, those are the motor nerve, as we have talked about it in the previous lecture. Posterior aspect, which is the sensory part. That is when you touch fire or a sharp object, you feel the pain because of the posterior cervical nerve roots. Anterior cervical nerve root then sends out the impulse to the finger tip so that the muscle of the finger is contracted and the finger is moved away very, very spontaneously, instantaneously away from the fire or the sharp object. This reflex action is done by this anterior root and posterior root with the complexity of the cervical vertebra, the spinal cord structure. Now, sometimes this area, as you can see, this compression of these vertebra body causes pressure. The pedicle, spinous process, lamina, they all can degenerate, dislocate, and cause by injury sometimes. Fracture sometimes takes place this area of the bones that you are seeing. All of these bone structure that you are seeing are prone for fracture. When we have cervical fracture, that is an emergency that we need to put that patient on traction, cervical traction, so that the nerve and the spinal cord is not damaged. Sometimes we find patient, they have severed cervical spinal cord. Think about Superman actor Christopher Reeve. He had cervical C1, and in between C2, the cervical spinal cord was severed because of injury. Very easy to dislocate, to injure, to fracture, and even cut off the spinal cord here. Spinal cord here runs like a little white fibrous material that you have the white matter and the gray matter inside, and all the nerve tracks there. So in order to just simply relieve the pain, we can do rhizotomy. Rhizotomy is just a resection of this area so that the nerve roots in that joint structure is not going to inflict any more pain. So you can see on the picture here on the left how a simple cyst-like structure is causing the compression on the nerve root that is emerging out of there. The arthritic changes of the joint, that is causing pressure here because of the nerve root right here adjacent, and because of the arthritic changes here, nerve root is, along with the area of the spinal cord, is having a lot of compressions. So these can be relieved by doing, by cutting these nerves. Now, but destruction of nerve root in this faucet joint eliminate pain. But what about motor nerve? Are we going to cut the motor nerve as well? No. We keep the anterior part, which is here, the motor nerve that is coming out of there, we identify them and we do not destroy them. If we cut the motor nerve, the movement, the hand, arm, shoulder would be impaired. We only do the sensory nerve, that is the posterior aspect. We cut those. We sometimes ablaze them with a laser or electrocautery specially designed to relieve the pain. That is called ablation surgery. The patient who are having excruciating pain, uh, they needed this type of rhizotomy. And this surgery can be done under fluoroscopy, and very quickly the patient can get relief from intractable pain. So cervical chordotomy or rhizotomy procedure. Anterior cervical discectomy. Traditionally, it was named after Dr. Claward, so that is why it's called Claward procedure also. But anterior cervical discectomy, that is how this procedure will be scheduled on your surgery schedule. You'll find on your schedule that patient so-and-so is having anterior cervical discectomy with or without fusion, and the labels that you're going to work. Maybe cervical 3, 4, 5, such as these labels will be reflected on your schedule. Again, same reason, pain in the around that area of the cervical disc. The pain that is causing, because of this disc problem there, that you find near the neck, shoulder, arm, all the way up to the hand. Sometimes we call radiculopathy, which means the electric shock-like pain that goes down the arm all the way up to the fingertip. That electric shock-like pain is caused by this disc material being compressed by the nearby structure, like the vertebra body or on the nerve root. So the disc material is now overgrown or ruptured, and the vertebra body became degenerated and causing pain on the nerve, spinal cord, or the nerve root itself. So that herniated disc or spondylosis, it is a condition of the spinal cord and the vertebral structure itself, can be fixed by removing the disc area, by removing the process here, cervical lamina process. Anterior part can be approached by supine position. Sometimes they require bone graft, and that bone graft is taken from either right hip or left hip iliac crest. So we put a little sandbag or roll blanket under that affected hip where the bone graft will be taken to elevate the area of the iliac crest for the surgeon to take the bone graft. The area is prepped properly. Go back here. The area is prepped properly. Anterior cervical area, that means the neck area, is prepped properly with betadine or whatever the surgeon's preference is. Then we use a laparotomy, small pediatric laparotomy drape, which has a smaller fenestrated hole there. We use that, or we have neck fenestrated drape, which is used for thyroid surgery. So we use that drape after we put barrier towels, 4 barrier towels around that area. Head will be tilted a little bit away from the surgical site, and head will be usually positioned such a way during the surgery the head is not going to move. So we put usually foam headrest, or sometimes we put tape around the forehead, so the head is kind of positioned with and secured with the operating room table. So during the surgery, head is not going to move and cause problem with exposure and hemostasis. So after the draping is done, then surgeon usually finds the landmark. The landmark is usually sternocleidomastoid muscle that runs from sternum all the way up to the mastoid process. It's the long strip of muscles that actually helps our head to move left to right, up and down, and turn any way we want. So the sternocleidomastoid process is important to find the landmark. Once the landmark is been marked with a marking pen, then the surgeon will take a number 10 blades on a number 3 handle. They will incise along the border that is created, the marking line that is created by him initially. Then he will take Adson with tooth pickup and Bovie to cauterize the soft tissue structure which is under the skin. Take a Metzenbaum scissors and DeBakey or his choice of tissue forceps to dissect the subcutaneous tissue, the tissue underneath where there is a muscle structure of the neck that is been bluntly dissected using the Metzenbaum scissor, kind of spread around, and then use a retractor of his choice, and that retractor would be this type of clawward retractor. Now he is exposed to the cervical vertebra area, and he's seeing those ligamental structure. He already identified the recurrent laryngeal nerve, the hypoglossal nerve, the carotid arteries, isolated them, put the metal blade side onto those artery area and retracted them medially, and lateral side, he's got all this muscle structure that is retracted laterally. That is why we have this prong can be used on the lateral side. There's this prong cannot damage the muscle, but on the medial aspect, we have the blade type of retractor, because the medial aspect, we have the carotid artery. So we cannot use prong there because that will puncture the carotid artery, and that would be a disaster. We don't want that. So we want a smooth, non-traumatic blade-like retractor on the carotid side. And the muscle area is retracted with the 4-prong, this type of retractor. When the retractor is used, a surgeon usually sees the anterior cervical area clearly. Then he's going to take a spinal needle and use fluoro, CR, to identify the level that he is targeting to work. If he wants to work, for example, cervical 4 and 5, he will place the needle in between cervical 4 and 5 and take a C-arm, identify it, confirm it, and then he will take the needle out and dissect that area, those ligaments, anterior longitudinal ligament. It dissects its way to get inside that disc area. So by doing that, he can use a deep retractor, and he can use minor dissecting tools like dissector, freer, penfield dissector, pituitary rongers, and he will take out the disc material which is causing the pressure, send it as a specimen. The gap that is created after removal of the disc, that is where he is going to put the bone graft, which is taken from the iliac crest. That bone graft can be shaped using depth gauge and the saw blade. Then the bone graft requires a impactor in order to place the bone graft in between the disc space. Let's look at where they will put the bone graft. They'll put the bone graft right here in between these two vertebrae, right here in this area. Let me show you another picture where you can see cervical area and the placement of bone graft. This picture. If we look at this picture and we make it, magnify this, right here you're seeing cervical 5 and 6. The disc material, this is the disc material up here, the light bluish color disc material. It is not really compressing against the nerve. This one is bad. He has taken out some of these, or she has taken out some of this disc material. And this area, the disc was really causing pressure. This is the spinal cord. This structure here you are seeing going through this canal, that's the spinal canal. And that is the spinal cord, actual spinal cord here. So if this material causes pressure on the spinal cord, nerve root, and everything around this nerve in this region is going to get very, very angry, and is going to cause intractable, excruciating pain, radiculopathy. Now, surgeon has removed this area and placed this iliac crest bone graft that has been taken from iliac crest and shaped it with a saw blade and ronger. When he found it's shaped properly, that fit in between the C5 and C6 vertebra, he placed it with an impactor. Impactor is basically a tap to use a mallet so that they can tap the bone inside this joint. Once this is done, it is still not stable. So they had to use a plate called cervical plate, and these screws, they go onto the vertebra above and below. Now, by doing this plating, screwing, and the fusion here, C5 and C6 level is stabilized. So this gap, the material is gone. Now it's replaced with a bone graft and plating, screwing. So this area is stabilized, and along with that, the pressure from the spinal cord is eliminated totally. According to this picture, this area, this material is also causing pressure. In this area, surgeon probably perhaps could have just eliminated the excess disc material from here and relieve the pressure. This is what it looks like from the top. From your perspective, you're going to see clawed retractor placed laterally, medially, superiorly, inferiorly, and expose the whole disc area. This area now you're seeing here. So this is how the anterior cervical discectomy with fusion with anterior cervical plating and screwing is done with a iliac crest bone graft. Now we can go back to the area where we see anterior cervical area laminectomy. Right here, the two retractors are placed and lamina is exposed, and they can use kerosene rongers and take slow bite at a time in order to remove this lamina from here. So instruments, we need plain minor dissecting set with knife, tissue forceps, Metzenbaum scissors, 1 or 2 hemostats. Then we need a retractor like this, bladed, clawward, or anything that will work as this blade and prong tip. And we need a bone graft holder, depth gauge, and bone graft impactor for bone graft insertion. We need pituitary rongers, kerosene rongers, and lamina spreader time to time. What this lamina spreader do? Lamina spreader is used to spread the lamina of above and below the area of the site, the actual surgery. If we are working on L4, so if we want to expose L4, we can use this lamina spreader into the L4 area and spread it. So L3 and L5 are spreaded, so we get enough exposure in between in the area of L4. So lamina spreader gives exposure as a retractor placed inside of the lamina or inside of the vertebra. Curette, like spinal fusion curette, they work in order to get bone, smooth the edges of the bone to make the fusion very smooth, to create the bone around the fusion to match with the actual bone graft. So there is no irregularities in between the bone used for the fusion and the bone structure around it. So spinal fusion curette does the final finishing job for the fusion. Now we are going to look at some other types of surgery that neurosurgeons are involved with, called sympathectomy. Sympathectomy is done because of long-term pain relief. So they have nerves or nervous system causing long-term pain because of the blood vessels around that area is compressed. To increase the blood vessels to leg or maybe to area of the arm, they do this nerve ablation procedure. We call it sympathectomy. They use laser. They can use simply electricity, or they can use some other means to destroy some chemical they can use to destroy the to clean the area, so the nervous system, so pain is decreased, blood flow is increased. The surgeon is not going to damage or remove or destroy any motor nervous system that is going to impair the person functionally. They only identify sensory nervous system and destroy those area, burn those sensory nervous area, sympathetic part. Time to time, patient complains about excessive sweating, and this is when a part of the sympathetic nerve or nerve root ganglia body around the thoracic or lumbar spine area, they can identify what is causing this problem, and they can resect that, destroy some fibers of those ganglia, not all of it, just few, by reducing the cause for excessive sweating. Here is a thoracic sympathectomy that we have seen the ganglia that runs around the vertebral body is identified in order to do some pain regarding the biliary system or pancreatic disease, sometime for hyperhidrosis, that is excessive sweating, excessive perspiration. They do this type of thoracic sympathectomy endoscopically. They put two portals here, one above the nipple area, one in the axillary area, and they put the scope through it, and they identify the vertebral body, ganglia around it. They use a nerve hook like this. With this nerve hook, they have attached it to the electric cautery. So use electric current to burn this, cut this off and coagulate this area. These are sympathetic chain. These are not motor chain, strictly chain for sensation, for sympathetic work. They can do it thoracic, they can do thoracolumbar, they can do lumbar, depending on what the pathology is. Basically, destroying the nerve root using electric current or laser. Neurosurgery also includes peripheral nerve repair. Here, we're seeing ulnar nerve that is emerging from the brachial plexus and going through the elbow, this muscle area, and running into the ulnar part of the hand. Now, here, the nerve emerges out of these triceps muscle groove and is exposed outside. This nerve can be felt by using palpation. We can touch this body of this nerve around this juncture of the elbow, where there is a groove there in between this humerus and the ulnar area, ulnar area of the hand bone. This can be caused by excessive tennis play. We call it tennis elbow. In that case, what the surgeon do, they release this area and transpose, they put the nerve behind the muscle group to keep it covered with the muscle and not create any type of friction type of injury with the bone. So they avoid the friction of the nerve on the bone joint by transposing this nerve to a safe area. Mostly they put the suture, the muscle in between the nerve and the bone prominence, so that to avoid the injury of the nerve by rubbing against the bone. The transposed ulnar nerve, that can be done with a local anesthesia. Here you are seeing how the nerve has been retracted using vessel loops, umbilical tapes, and it is sutured back within this group of the muscles, protecting the nerve from injury. Here is injury of this nerve. Sometimes this nerve can be severe. So if this nerve is severe, we can use microvascular nerve and anastomosis using neural suture and microscope. This suture is placed on the nerve's sheath. The nerve has, these type of peripheral nerve has advantage. The advantage is they're covered with myelin. This myelin is a neurolemma, a type of epithelial cell that covers this nerve. The yellow shiny material that you're seeing, that is the covering of the nerve, peripheral nerve. And inside we actually have the nerve. So this neuron, is covered with this neurolemma, the myelinated sheath, and the repair is done on that myelin membrane. When it is done, this myelin regenerates inside and outside, and the anastomosis is complete. This nerve within few weeks starts to signal appropriately. This is only possible on peripheral nerve injury. If we have a spinal cord or cranial nerve injury, we cannot have this success of neurography or repair of the nerve, because we don't have myelin or neurolemma on those tissues. It's only possible for peripheral nerve injury. Peripheral nerve can grow back after, if you damage it, it can still grow back just because of these myelin sheath they have. Usually we get a question about that myelin sheath, having the myelin sheath and the advantage of that. So neurography is another type of surgery that neurosurgeons do. Mostly this surgery is done by hand fellows or hand surgeons. This is their territory. They work on the arm and hand area, and they're specialized in all these muscles, tendons, nerves, and how to repair them. They have technology that is available. They can reattach arm or hand, finger, or any areas of the hand. So that is part of their hand reconstruction surgery. If you get an opportunity to see total amputated hand reconstruction, when you have patient coming in with a resected hand, amputated hand, 100% amputated hand, and how the hand reconstruction surgery is done slowly by repairing this bone first, then the muscle and tendon they put together using meticulous suturing technique. They put together nerve and vessels, All of these are done using microvascular technique and microvascular suturing technique. So hand reconstruction surgery is another area where the nerve is being repaired. So if you have a opportunity sometime, please take a look. Carpal tunnel, very common problem with people who are working on the desktop with the keyboard or receptionist. They have this problem after long-term use of the hand monotonously. What happened is median nerve, this yellow nerve that is coming from the brachial plexus, that gives sensations and motor activity to the area, the palm side of the hand, all of these fingers, like except the little finger. Little finger gets the nerve from the ulnar nerve, but thumb, index finger, middle finger, and this fourth finger here, you get median nerve to innervate. And there is a ligament we call transverse carpal ligament, and it is shown here. It is seated right on top of the carpal bones. You have radius bone right here, ulnar bone right here. And right after that, we have a group of carpal bones. And on top of that carpal bones, we have ligament that is called transverse carpal ligament. And this median nerve is almost like a size of half of our index finger. It's very large, very visible. And this nerve passes underneath that transverse carpal ligament. Now, when we have excessive work with this carpal joint, this transverse carpal ligament starts to compress on that median nerve, causing pain, excruciating pain, the finger, tingling sensations all the time, electrocution type of pain all the time, sharp pain. Sometimes these patients, they wake up in the middle of the night when they have shooting pain of the finger, thumb, index finger, because of this median nerve is compressed by the transverse carpal ligament. So the technique is carpal tunnel release. So what they do, they decompress this carpal tunnel by cutting this transverse ligament. They really cut this ligament off. They take a knife, go on top of the skin, then expose this transverse carpal ligament, and they identify the median nerve underneath it, and they cut it right on top of the transverse carpal ligament, where the median nerve is located right underneath. By doing that, the pressure on the median nerve is gone. Decompression procedure is done. This decompression of the median nerve is called carpal tunnel release. Again, this can be done by 3 groups of surgeons. Plastic surgeon, they learn how to do this. Hand surgeon, they claim this is their territory. They don't want to share this carpal tunnel with anybody else. So there is a big debate out there who will do this surgery. They are still fighting on this carpal tunnel. And the neurosurgeons sometimes do this. They say this is peripheral nerve, so this is our territory, so they will repair it. Right now, hand surgeons are winning the debate. Hand surgeons are doing the majority of the procedures on the carpal tunnel release. Sometimes they do this without cutting the skin. They can use endoscopic carpal tunnel dissector. They have developed endoscopes that can go in through a little portal and has a sliding blade that can cut this transverse curval ligament without making a skin incision. I have seen some of these hand surgeons, they do on a daily, they schedule 12 to 15 cases a day. It's almost like a assembly line work. One patient come in, endoscope is inserted, cut the ligament, put the dressing on, go. Next patient come in, portal hole, the blade is used to cut the transverse ligament, put the dressing on, go. Third patient come in. It takes more time to do the turnover. Surgery time is a couple of minutes, and it can be done under local, no anesthesia, so there is no recovery time. People will come in, get the ligament cut, put dressing on, and they can go home since there is no anesthesia. So the actual procedure is a couple of minutes, but we have to turn the room over, so that takes 15 minutes. So they can do 10 to 15 cases a day, and they're trying to increase that speed. Some says, jokingly, maybe this can be done at the drive-through kiosk. Like patient will come in to the car and the surgeon will sit inside like a McDonald's, and the patient will extend the hand, the surgeon will put in the endoscope, cut it, and let the person drive through. That is just a joke. Don't take it seriously. That's not going to happen because we have to do stero technique. We have to do aseptic technique. Otherwise, the surgery will fail. So we need an operating room. And these are done in the outpatient surgery center mostly, because these are patients come in and out. They can recover very quickly. One object that we use is a lead hand. Lead is malleable. So this hand, this structure can be used to retract fingers while the surgeon is operating on the carpal area or any area around this section of the hand. Usually works better when they're doing microscopic anastomosis of nerve or vessels. So lead hand is another instrument that you need to get when you're doing hand surgery. So that is where I will stop. Now I'm going to ask for any questions that you may have in this part of the neurosurgery. Do you have any questions at this time? Stop the recording part.